Greetings. We're going to be talking about the brachial plexus. Brachium refers to the arm and plexus to a bunch of nerves. Brachial plexus is basically the network of nerves that supply the upper limb. It consists of roots, trunks, divisions, cords, and terminal nerves. The roots emerge from the intervertebral foramen, constituted by the anterior primary rami fibers of C5, C6, C7, C8, and T1 spinal nerves. Occasionally, there are contributions from C4 and T2 spinal nerves. The prefixed plexus is formed from the contribution of C4 and the postfixed is formed from the contribution of T2. The trunks. They originate from the roots, and both the roots and trunks lie in the posterior triangle of the neck. Supraclavicular, that is above the level of the clavicle. The divisions arise from the trunks and are found beneath the clavicle. Cords and terminal nerves, which arise from the divisions, are found infraclavicular, that is below the level of the clavicle and in the axilla. The roots are observed to be in between the anterior scalene and the middle scalene muscles. They also receive gray rami communicants from the sympathetic chain. Trunks. They originate from the roots, pass over the first rib, and enter the axilla. The three in number: the superior or upper trunk, the roots of C5 and C6 form them, the middle trunk formed from the roots of C7, and the inferior or lower trunk formed from the roots of C8 and T1. Each of the trunks give off ventral and dorsal divisions, which club together to form cords. The cords are of the names lateral cord, medial cord, and the posterior cord. They get their names with respect to their relation to the axillary artery. From the diagram given, we can observe that the lateral cord lies lateral to the axillary artery, posterior cord posterior to the axillary artery, medial cord medial to the axillary artery. The lateral cord is formed from the anterior divisions of the superior or upper and the middle trunk, that is C5, C6, and C7 anterior divisions. The medial cord is formed from the ventral division of the inferior trunk, that is from C8 and T1, and the posterior cord from the posterior divisions of all the three trunks, that is from C5 to T1. Moving on to the branches. The branches can be classified into three types: the ones from the roots, the ones from the trunks, and the ones from the cords. The ones from the roots, two of them, dorsal scapular and long thoracic nerve to bell. The dorsal scapular nerve, its origin is the C5 root. It's a supraclavicular branch that passes posteriorly, often pierces the middle scalene muscle, runs along the medial border of the scapula. It supplies the rhomboid major and the minor muscles. Long thoracic nerve to bell. Its origin are the C5 to C7 roots. It passes vertically down the neck along the medial wall of the axilla, lies on the superficial aspect of the serratus anterior muscle, and supplies it. Moving on to the branches of the trunk. Only the upper trunk gives off branches, the middle and the lower do not. Suprascapular nerve. Its origin is the upper trunk, spinal segment is C5 and C6. It passes through the posterior triangle of the neck, through the suprascapular foramen, and enters the posterior scapular region. It is accompanied by the suprascapular artery and supplies the supraspinatus and the infraspinatus muscle. Nerve to subclavius. It originates from the upper trunk, spinal segment C5 and C6. It passes anteroinferiorly over the subclavian vessels and supplies the subclavius muscle. The point to be noted is that all the branches from the roots and the trunks are supraclavicular, while all the branches from the cords are referred to as infraclavicular. Branches from the cords. Lateral pectoral nerve is a branch from the lateral cord. Its spinal segment C5 to C7. It is accompanied by the thoracoacromial artery, pierces the clavipectoral fascia, passes between the subclavius and pectoralis minor, and supplies the pectoralis major muscle. It gives off a communicating branch to the medial pectoral nerve. Musculocutaneous. As the name suggests, it has both a motor function and a sensory function. Motor function being that it supplies the muscles of the anterior compartment of the arm, and sensory function being that it supplies the skin over the lateral side of the forearm. It pierces the coracobrachialis muscle, passes in between the biceps brachii and brachialis, terminates as the lateral cutaneous nerve of the forearm. Medial pectoral nerve. It arises from the medial cord, spinal segment C8T1, an infraclavicular branch that receives a communicating branch from the lateral pectoral nerve and passes in between the axillary artery and vein and supplies the pectoralis major and minor muscles. Medial cutaneous nerve of the arm. It originates from the medial cord, passes through the axilla where it communicates with the intercostobrachial nerve of T2 and supplies the skin over the medial side of distal 1/3 of the arm. The medial cutaneous nerve of the forearm. It originates distal to the medial cutaneous nerve of the arm, passes out of the axilla into the arm, giving off a branch to the skin over biceps brachii, penetrates the deep fascia accompanied by the basilic vein over the anterior surface of the forearm down to the wrist. Supplies the skin over the medial side of the forearm. Median nerve. It has two roots, one root from the lateral cord and the other from the medial cord. Spinal origin from C6 to T1. Supplies the muscles of the front of the forearm and the thenar eminence. It's formed anterior to the third part of the axillary artery. It lies anterior to the brachial artery in the arm and then passes into the forearm. Ulnar nerve. Ulnar nerve arises from the medial cord, spinal origin being C8 and T1. Supplies 1.5 muscles of the forearm and 15 intrinsic muscles of the palm. It receives C7 fibers through a communicating branch from the lateral root of the median nerve. Moving on to the branches of the posterior cord. The superior subscapular nerve. It arises from the posterior cord, short, and passes into the subscapularis muscle and supplies it. The thoracodorsal nerve arises from the posterior cord, passes vertically along the posterior axillary wall, penetrates the latissimus dorsi muscle and supplies it. Inferior subscapular arises from the posterior cord, passes inferiorly along the posterior axillary wall and supplies the subscapularis muscle along with the superior subscapular nerve, also supplies the teres major muscle. Axillary nerve. Axillary nerve is a branch of the posterior cord which passes inferiorly and laterally along the posterior wall of the axilla, exits the axilla through the quadrangular space, passes posteriorly around the surgical neck of the humerus, accompanied by the posterior circumflex humeral artery. It has both a motor and a sensory function. The motor function being that it supplies the deltoid and teres minor muscles. Sensory function supplies the skin over the upper lateral part of the arm. It is an infraclavicular branch. Radial nerve. The radial nerve arises from the posterior cord. Spinal segments C5 to T1, the thickest nerve, supplies all the posterior compartment muscles and supplies the skin over the posterior aspect of the arm and the forearm. It is an infraclavicular branch. This slide gives you a brief description about the course of each of the nerves. Moving on to the clinical aspect. Injury to the brachial plexus can take part at 3 levels: at the root, at the trunk, at the divisions and the cords. At the root level, it is caused by spinal cord injury in the cervical region and direct pulling injuries. Trunk injuries are caused due to severe trauma to the first rib. As we have already seen, the trunks pass over the first rib after originating from the roots. Divisions and cords injury, it is mainly due to the dislocation of the glenohumeral joint, that is the shoulder joint. Brachial plexus block, it basically refers to the anesthetic that is given in order to perform a surgery in the upper limb. It is done because further down the upper limb, anesthetizing the nerves becomes cumbersome, because each of the branches have to be individually identified and only then they can be anesthetized. The procedure involves palpating the axillary artery by abducting the arm and rotating it externally. That is, you place your arms over your head, the axillary sheath is located, and the local anesthetic is injected on either side of the axillary artery. As we have seen before, the lateral cord lies lateral to the axillary artery, medial cord medial to the axillary artery, and the posterior cord posterior to the axillary artery. So, providing the anesthesia on the sides of the axillary artery will help create a block in the brachial plexus. The potential complications that could arise are inadvertent arterial injection of the anesthetic. That is, the anesthetic could be injected into the artery directly, or the needle could damage the axillary artery or the nerves of the plexus. Erb's paralysis. Erb's paralysis occurs due to an injury in the brachial plexus in the upper trunk at a point called the Erb's point. The Erb's point is the point where 6 nerves meet: the C5, C6 roots, the nerve to subclavius and the suprascapular nerve from the trunks, and the anterior and the posterior divisions of the upper trunk. It is caused due to the undue separation of the head from the shoulder. This deformity causes the forearm to be extended and pronated. The arm is adducted and medially rotated. It is also known as the waiter's or policeman's or porter's dip hand. Klumpke's paralysis. Klumpke's paralysis occurs due to an injury in the brachial plexus in the lower trunk. It is caused due to the undue abduction of the arm, and the deformity is claw hand, hyperextension of the metacarpophalangeal joints, and flexion of the interphalangeal joints. Winging of scapula. In winging of scapula, the nerve affected is the long thoracic nerve to bell. It is caused by sudden pressure on the shoulder or carrying heavy loads. It causes excessive prominence of the medial border of the scapula. This is because the serratus anterior muscle loses its bulk, and thus the does not pull the medial border towards the body. The disability caused due to winging of scapula include loss in pushing and pulling functions and overhead abduction of the hand. Axillary nerve injury and dorsal scapular neuropathy. Axillary nerve injury, the cause is shoulder dislocation. The consequences include loss of abduction and sensory loss over half of the deltoid. This is called the regimental batch sign. Dorsal scapular neuropathy, it is caused by shoulder joint dislocation and also by the fracture of the surgical neck of the humerus. The consequences include weakening of the muscles supraspinatus and infraspinatus, leading to mild winging of the scapula. Radial nerve injury. It results in loss of extension of the elbow and in wrist drop. Median nerve injury results in the inability to flex. Medial claw hand, which is marked clawing of the first 3 digits. Ape thumb deformity due to the paralysis of the thenar muscles. Ulnar nerve injury causes ulnar claw hand, marked clawing of the 4th and 5th digits. Complete claw hand is caused when both the ulnar and the median nerves are injured. From this diagram, we can see the branches coming from the roots. The dorsal scapular nerve, long thoracic nerve. The ones from the trunks, suprascapular nerve, nerve to subclavius from the upper trunk. The nerves from the cords, lateral